So good morning, everyone. In the next 10 minutes, I'll talk about LIV selection, and it's good to follow Stuart's talk. What does the literature say? Where can you stop safely? I think if you look at it, if you do a literature search, there's conflicting data right now. This is a paper from Rothman Group, basically showing that clearly stopping at C7, you almost double the revision rate compared to crossing the junction. And also there's a more adjacent level disease at C7, 15% compared to the crossing the junction. And then odds ratio of reoperation, 2.29. Other studies. Another study showing that crossing the junction is better than not crossing the junction. But again, we have to understand all these sort of studies that we look at right now. The biggest limitation is selection bias. Most of them are retrospective studies, so the surgeons already picked the approach that they think is best for the patient. So this is another meta-analysis looking at all the literature available, essentially multiple papers, and crossing the junction essentially is superior in terms of higher fusion rate and lower reoperation rate. So does the literature, stop there? Of course not. If you look at this more recent paper that came out of Korea by Dong-Ho Lee, they looked at stopping at C7 versus crossing the junction. There's no difference in terms of complication rate, but crossing the junction, actually people had more neck pain. Obviously, there's more muscle dissection. I think a lot of times, how do you stop at C7 also matters. Is it the pedicle screw, or is it you dissect lower down and you're using a small lateral mass screw? And how long is UIV? Oftentimes these papers, say we did a long segment posterior fixation. You have no idea, did they stop at C2, 3, 4? Because the length of fixation also matters. So the UIV selection will affect the stress that you place the LIV at. And also, a lot of times deformity are lumped in with degenerative cases, and that further complicate the literature. So again, this is a study showing that there's stopping at C7 does not have adverse effect. In fact, there's less neck pain in that group. And this is a more recent paper, and it's actually presented here at this meeting. So I think it's compared to all the literatures available, it's a large number, and I think it's a great study because they do actually decipher the UIV as well. So over 800, close to 900 patients from Kaiser, and with about 4 to 5 year follow-up, and looked at crossing versus not crossing, as well as what happens if you have C3, 4, 5 as the UIV. And as we can see here, from C3 to 7 and the C3 to T1, T2, statistically not a huge difference, but there's slightly higher in terms of adjacent level operation at the level that you stop short of junction. And again, if you think about it, if we think about the arthroplasty versus ACDF data, the difference in adjacent level degeneration really gets magnified over time. So, in 1 year, there may not be a huge difference. 5 years, you start seeing some difference. 10 years now, we know it's half of the reoperation rate at the adjacent level for arthroplasty versus ACDF. So, I think this is a great study. It's 4 to 5 years follow-up, but if we have 10-year data, it would be even better. We may see a difference magnified with that. Okay, next. And this paper also looked at all previous papers on this topic. Again, there's controversial data on this. So again, just to reiterate some of the limitations of the current study. Again, selection bias, so all the papers are not randomized. So as surgeons, we pick what we think is best. If you have a person who has a deformity with a significant sagittal imbalance, you're probably going to cross the junction to get a better realignment. But if it's just a degen case with a good lordosis and good SVA, you perhaps stop short at the junction and stop at C6 or C7. And also the UIV is important. Most of the studies doesn't say which UIV, and if you do decide to separate out the UIV and LIV, the study numbers become too small. So that's the limitation of a lot of the studies currently. And also, as many others has mentioned at this meeting, is that the muscle soft tissue dissection techniques and how extensive people do the dissection is not described, and it varies by surgeon. And whether you have a younger trainee doing the dissection versus you're there the whole time makes a huge difference. And last thing is that the variable follow-up. So what does the biomechanical data suggest? This is a paper came out of Utah, and you can see that they used 6 cadavers and basically did progressively more decompression and fusion. So start off with a single level posterior fusion to a single level lami fusion to a 2-level lami fusion all the way up to from C2 to 7. And I think this tells us a lot. They tested the specimen on axial rotation, flexion extension, as well as lateral bending. And you can see, I want to sort of focus your attention on the last box. From C2 to 7, fusion with C3 to 6 lami and C2 to 7 lami, there's a significant increase in flexion extension, suggesting even, we know the attachment C2 is very important, but maybe even the 2-3 ligaments as well as C3 lamina may even provide additional resistance to flexion extension in that. So clearly UIV and the ligamentous dissection will affect the lower level, adjacent level, how much biomechanical stress it has. And there's no question, there's a graduated increase. As the more levels you fuse, more stress is going to have on the lower level, just because you start to have a longer and longer biomechanical lever arm. And this is another study done by Dan Rue, where they basically looked at what's the optimal level to stop in the thoracic area, and they actually found T2, T3 level had the biggest drop in terms of the ILRV. So this paper actually suggests perhaps stopping at T3 is better. So does the cervical alignment matter? This is another study showing that seems like actually where you stop doesn't really matter as long as you had good alignment. And people with poor alignment, doesn't matter where you stopped, they did worse. And here's another paper basically showing that time follow-up matters. So at before 5 years, the two groups are similar, but after, if you're looking at more than 5 years, the adjacent level revision rate starts to go up for the C6 and C7 group as the ILRV. And this is a paper came out of UCSF, our group, showing that crossing the junction does help to get you better correction in terms of the sagittal alignment as well as the cervical lordosis, keeping the T1 slope and the cervical lordosis in a more harmonious relationship. So this is an example of stopping short of the upper thoracic spine. You can see the SVA is increased. This is the crossing the junction. So I won't belabor this. Just with the last minute or so, I do want to go over a couple examples. And also the take-home message is that UIV will affect the amount of stress the LRV sees or the level below. So that should influence your decision. And each additional level fused will increase the lever arm on the distal adjacent level. And dorsal ligamentous complex is very important. So even some biomechanical data suggesting that C2-3 ligaments may even be important just as much as the C2 attachments. And if you're doing a deformity correction, if you're going up to C2, perhaps it's better to cross the junction because going up to C2 will dramatically increase the stress at C7, T1. And if you're stopping at C7, pedicle screw may be better because the entry point is more superior and less muscle dissection caudally. And if you are stopping at T2 or crossing the junction, so for deformity cases, I think stopping at T2 or T3 with more than just 2 anchor points caudally will be better. And if you are crossing the junction, and especially if you're going up to C3 for deformity case, maybe better to go up to C2, give you the better fixation, because we have all seen that there's iatrogenic kyphosis coming from inadequate upper level fixation.